Hello, everyone. I'm Annie Peters. I'm the Director of Research and Education at NAATP, and I have here with me Dr. John Kelly, Professor of Psychiatry at Harvard Medical School, who also directs the Recovery Research Institute. And we're talking to, at NAATP, we're trying to talk to some researchers who are doing good work on data collection and measurement in the field of addiction treatment so that our members, particularly at this time of the COVID crisis, we want people to be talking about data collection, looking at outcomes, looking at progress measurement, implementing that at your treatment center if you haven't, or enhancing that and kind of combining our efforts nationally to look at this data. And so, Dr. Kelly, I know this is something you spoke about at NAATP last year, and so this is pretty much something that you are actively engaged in right now. So we were just talking, I'd love for you to say again, why this is such an important thing to be talking about right now.
Thanks, Annie. Well, I don't think there's anything more powerful that we can have as providers, as treatment providers, as a treatment industry than data, than having good, valid data points to present to payers, to the public, that they really are a strength. I've proven it to myself time and time again. Even a little bit of data that's valid can go a very long way to winning the trust of payers and the public. And of course, as I mentioned in my talk, the addiction overall, substance use disorders, and the addiction treatment industry, we face we have to try twice as hard to prove ourselves, I think, just because the nature of these conditions, they're stigmatized, the industry is stigmatized. And so anything that we can do to prove ourselves, to prove that we are helping people and that we are thoughtful about how we're helping people, who we're not helping, so we can identify those cases and improve what we do to help those individuals better, is going to be a good thing. And so there are a number of different ways to do that, of course, and some of which I mentioned in my talk last year. And there are a number of different efforts nationally that are going on to do that in terms of measuring, taking measures at the point of care, like we would for hypertension or diabetes, where we would capture physical vital signs, like blood pressure or blood sugar, to measure the progress of treatment and also to direct treatment. And now, as I've talked about, is to try and capture what some people term mental health vital signs or addiction vital signs, which are we don't really have good biomarkers like we do for hypertension and diabetes, so we have to rely on patient report. And so there are a number of different ways that we can capture patients' reports, which are valid, have been validated, so we can capture those at the point of care, that we can summarize, aggregate, and relate and graphically present those kinds of scores to patients and providers and program directors, so we can see how we're performing and who's falling through the cracks.
Mm-hmm. So is there a recommendation you would have if there were I know there are a number of treatment providers that do some of this already, but others are only looking at client satisfaction scores and things like that, collecting that kind of data. What would you recommend as far as the addiction vital signs that could be measured across the board?
I think there's a couple of ways to think about it. If you have an outpatient setting, so in other words, if people are coming to your outpatient program and returning home, at the times they're not in your care, then obviously they have the opportunity to use substances. So one thing you can measure, of course, is substance use. So you can measure using urine toxicology screens, breathalyzers. Those objective measures are very powerful, very useful if you collect them systematically as a matter of routine care, and as well as paper and pencil measures, so-called paper and pencil, so self-report measures. These can be captured, of course, on tablet devices, in computers, in waiting rooms, and can be summarized and aggregated that way. But to look at things like days of use, risky use, IV drug use, but also intermediate measures motivation, coping, self-efficacy, pain, craving, these kind of measures, which are targets of our treatments, of course, but we don't do a good job of measuring their progress. We may ask the patient, but to actually get the metrics on those can be very powerful to monitor those and chart the progress of those measures over time.
Mm-hmm.
On the inpatient side, it's a little more tricky, of course, because you're not measuring substance use per se, but you're hoping something should change between the day they come in and the day they leave. The question is, what should change?
Mm-hmm.
Okay. And that's the thing, that's where our theories come in, is obviously which is supposed to guide our treatment, because if you think about it, what are we actually targeting during residential care? You know, we're hoping to have some influence up here in terms of changing people's attitudes about the need to do certain things post-discharge from inpatient care, from residential care, i.e. maybe continuing care. Maybe that's the most important thing, is that they engage in some kind of combination of continuing care, in a combination of professional, mutual help, medications, or whatever it is that can help that person increase the chances of them staying in remission. So there could be attitudinal changes in people's perceptions of the need to take a medication or the need to engage in continuing care. Expectancies about mutual help involvement.
Mm-hmm.
These kinds of measures have been developed and validated. Commitment to recovery. So the kind of construct of commitment to recovery or motivation for abstinence and recovery. Self-efficacy. That should change. People's confidence in their ability to maintain sobriety and recovery should go up. Coping skills should go up. Their perceptions about the importance of the need to change their social network. They can't really change their social network during a residential stay, but they can certainly change their perceptions of the need to do that, the importance of avoiding high-risk friends and adopting low-risk friends and people into their social networks. All those things can be measured during a residential stay to address those other kinds of what we call intermediate outcomes, or that explain ultimate outcomes.
And whether it's residential or outpatient, and something that comes to mind that is probably particularly salient right now during COVID is how people are doing as far as recovery capital. And I don't know if you want to say a little bit about the BARC, or that is a tool that you've developed, and that would be something that would be easily implemented and is available, and why that might be particularly salient right now.
Mm-hmm. Yeah. I mean, you know, this whole construct of recovery capital, and you can think of recovery capital as kind of the broad array of resources that people can draw upon to help them in a recovery attempt. So it can be individual capital, so it'd be kind of mental health and physical health, as well as social capital, like as I mentioned, your social network, the status of that social network in terms of its drug and alcohol use and harmful use. As well as things like employment, education, and income that can help people to just have and housing that can help people just get a measure of stability to help stay in remission. There are 2 or 3 measures now. There's more coming down the pike in terms of validated measures of recovery capital. We developed a brief one, which is just a 10-item one, takes about a minute to complete, which can be implemented easily in clinical settings. So that's one of the reasons why we wanted to do it, to use it in clinical settings, but also for research purposes when we have a broad array of constructs we're trying to measure. We want to maximize our bandwidth, so we have capture different constructs briefly. But the nice thing about the BARC is just 10 items, takes about a minute to complete, and can capture the degree of recovery capital that people may have. It's generally more loaded towards social capital, in part because that's a kind of a major player. As I mentioned, these social networks are major players in terms of the chances, influencing the chances of someone's sustained remission after treatment.
Mm-hmm. Right. And something we really want to know about, particularly now if we've transitioned to telehealth, we really are interested in how people are connecting socially when it's difficult to do
Yeah, well, I think especially now, right now with COVID-19, is that there's a whole migration to online services, and people are really hurting with that deprivation of the social interaction. Now, it is mitigated, of course, by things like Zoom and these social media channels that people can utilize to access that social support. But it's really tough if you're leaving treatment or have left treatment recently and trying to get connected in those circumstances, right? Because you don't have the meeting before the meeting or the meeting after the meeting that really facilitates that connection with others. So that can be really tough right now. But so important as a second best is that people can get on these social media connections via Zoom and so on. And so we need to be much more proactive, obviously, about trying to facilitate that. But it's new to us all because they've really had a really secondary role. All these social network sites, the telemedicine has been second place to in person. And so it's kind of a new paradigm here with all of that. We're actually measuring that right now. We're looking at that in a couple of big longitudinal studies where we're now measuring much more aggressively, measuring the degree to which people are utilizing these online services and how they're benefiting from them.
Mm-hmm. Okay.
And how they can be improved also.
Mm-hmm. And the system that you developed, is that something that's accessible at this time for providers or not yet?
Yeah, this measurement system that we have is it's in the third iteration right now. It's not available publicly right now. It is a measurement assisted practice system. In other words, it's designed to assist practice just the same as you would take blood pressure for hypertension to direct care and the level of treatment that you provide and what kind of treatment, or blood sugar to direct diabetes care, etc., or A1C. It's analogous to that. So it uses standardized, validated brief tools that can be reported by patients very quickly at the point of care. And it's automatically summarized, aggregated, related, and graphically presented. So the clinicians can see progress, and then they can show the patient that progress or lack of progress, and also trends in risk, of course, which can head off a relapse before it happens. So that's what we've got nicely developed now, but we haven't, not to the point where we're ready to dish it out to providers yet. But I can't wait for that to happen, because I think, and we're going to make it free or as cheap as possible, and all of the measures that we use in that are freely available, so you don't have to pay for the measures, no proprietary aspects to the measures, so that people can just use that. I'm excited about it because I really feel that the treatment field, particularly addiction, we need these behavioral indices. We need these indices and intermediate outcomes measured so that we can prove to ourselves that we're having the impact that we want, and also to payers and the public.
Excellent. Okay, well, thank you so much for your time. I really appreciate it. I think this is a really valuable message to our members at this time. And thanks so much, Dr. Kelly, for your time.
My pleasure, Annie. Nice talking to you.